Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY 5 resident at the University of Pittsburgh, and today, in our next installment of the Head and Neck Cancer series, we will be reviewing nasopharyngeal cancer. The nasopharynx, remember, is the area of the pharynx located just posterior to the nasal cavity and superior to the oropharynx. Some of the important anatomy locations are pointed out here on this scan. So the eustachian tube is bounded by a structure known as the torus tubarius that kind of juts out just posterior to the eustachian tube. And right behind that is a little cavity known as the fossa of Rosenmuller. And the fossa of Rosenmuller is actually the most common origin of nasopharyngeal squamous cell carcinoma. So those are some of the important anatomical features to be able to identify on a CT scan for the nasopharynx. And in terms of the boundaries of the nasopharynx, remember we have the posterior nares and the posterior margin of the nasal septum anteriorly. Posteriorly, it's actually bounded by the C1 and C2 vertebral bodies. Superiorly, the boundary is the base of skull or the basosphenoid. Inferiorly, our boundary is the soft palate, because inferior to that, we're then getting into the oropharynx. And then laterally, it's those areas that I pointed out earlier, which are the eustachian tube, torus tubarius, and the fossa of Rosenmuller. Any cancer that arises along a mucosal surface can often be very tricky to visualize on a CT scan. And the same applies for nasopharyngeal cancer, I think. But oftentimes the trick to identifying the abnormalities is to identify the normal anatomy. So look for the eustachian tube, torus tubarius, and the fossa of Rosenmuller. And if you're not seeing these structures clearly delineated, as we see on the CT scan here, and there is some type of fullness or mass kind of interfering with that normal anatomy, that can be a hint that that is where the tumor is. And obviously, if the tumor is more locally advanced, invading into the base of skull and things like that, then you're going to see, more clearly be able to visualize the tumor. Just to switch gears and address a little bit of epidemiology, I think it's important to realize that nasopharyngeal cancer is actually fairly rare in the United States, but it's extremely common in Asia, South China, Southeast Asia, and North Africa. In fact, it's actually considered endemic in those regions. And very commonly, just like we see in oropharyngeal cancer, oftentimes these cancers are HPV mediated. Nasopharyngeal cancers are actually most commonly related to Epstein-Barr virus or EBV infection. So the same virus that causes mononucleosis. In China and other Asian countries in North Africa where nasopharyngeal cancer is endemic, the vast majority of cases, almost all, are always associated with EBV infection. In the United States, oftentimes cancers are actually not associated with EBV infection. So they end up leading to different histologies of nasopharyngeal cancer, and we will go over that in more detail later in this talk. But for now, just realize that nasopharyngeal cancer is not as common in the US, but it is endemic in parts of Asia and North Africa. And oftentimes it is related to EBV infection. The management of nasopharyngeal cancer, just because of the location and how close it is to the base of skull, is often non-operative. In fact, when we go through the treatment paradigm, all of the treatments are, either radiation or chemoradiation, with or without induction or adjuvant chemotherapy really is how we manage nasopharyngeal cancer. And the reason for this is that it is so close to the base of skull and it can oftentimes have cranial nerve involvement with neural deficits. It's a really challenging location to access and to remove without significant functional deficits. And so therefore the management is typically non-operative. As always, my hope with this talk is to relay some of the key background information for nasopharyngeal cancer, sort of focusing on the pieces in terms of risk factors, pathology, and EBV levels, things that are unique to nasopharyngeal cancer compared to the other disease sites that we've already gone over in head and neck. talk about the staging, treatment paradigm, and then a lot about the evidence, specifically focusing mostly on evidence for adding chemotherapy for nasopharyngeal cancer. Let's get started with some background. As we've said, EBV is a major risk factor for nasopharyngeal cancer, and EBV infection is actually associated with about 95% of cases in endemic areas, so the vast majority of cases in countries like China, Southeast Asia, North Africa. In non-endemic areas, EBV-associated infections still can be seen, and I've definitely seen it in clinic. It's hard to estimate exactly how many, but about 20% or more of cases in non-endemic areas, such as the United States. But a lot of cases in the US are also not related to EBV. In terms of the mechanism for EBV pathogenesis, I think this diagram shows quite a complicated mechanism, but essentially what happens is once infected with EBV, it can become latent and activate signaling pathways, often through NF-kappa B, that then lead to carcinogenesis. And there are some key proteins to be a little bit familiar with that are encoded by EBV genes and lead to that carcinogenesis. So a key protein to know is LMP. So there's an LMP1 and there's also an LMP2 protein. And these LMP proteins are latent proteins that play roles in basically regulating signaling pathways, promoting cell growth and tumor survival. So I would say LMP is kind of the most important protein to associate with EBV. There's another, there are some other ones as well, but I think LMP is one that comes up commonly and can be tested for. So it's good to just associate that with EBV. Other risk factors to associate with nasopharyngeal cancer include salt-preserved fish, preserved foods in general, low fruit or vegetable diets, tobacco history, having a family history, and HPV can also lead to nasopharyngeal cancer. So these are some of the important risk factors to keep in mind. EBV definitely the most important. In terms of presentation for nasopharyngeal cancer, lymph node involvement at diagnosis is extremely common, occurring in about 75 to 90% of cases, with bilateral disease in about 50% of cases. And so most often the presentation is actually going to be with a painless neck mass. Patients might experience some nasal or ear symptoms such as fullness or congestion. Remember, the opening to the eustachian tube is into the nasopharynx. So if there's a mass there, people are going to perceive that through their eustachian tube. It can lead to headache, diplopia. Oftentimes the diplopia is related to local invasion, and we'll talk a little bit about the anatomy of the nerves and the cavernous sinus and things like that. And cavernous sinus invasion can also lead to a triad known as Jacob's triad. And this is a triad of vision loss, ophthalmoplegia, and trigeminal neuralgia from cavernous sinus invasion. So neurological symptoms are, typically more common with nasopharyngeal cancer patients just because of the proximity to the base of skull and the brainstem. So it's always important to do a thorough neurological exam in these patients. Other symptoms can be facial numbness, and there can be dysphagia, hoarseness, Horner syndrome, cranial nerve 9 deficits. So there are a couple of other syndromes, Villa-Rett syndrome of lateral RPN compression on cranial nerve 9 through 12, or Vernay's syndrome of invasion into the jugular foramen. So again, all of these things are related to neural invasion that is possible depending on how aggressive the cancer is, where it's located, and where it's invading. So again, very important to do a thorough neurological exam in these patients. We already said that, most of the time these patients are already going to present with lymph node involvement in about 75 to 90% of cases, and about 5 to 11% of patients can actually have metastatic disease at the time of diagnosis. And if metastatic, the most common sites for distant metastasis are bone, lung, and liver. I want to take a moment to review some important base of skull anatomy because, as we just said, because the nasopharynx is located just inferior to the base of skull, so close to the clivus and the basosphenoid, if these tumors are more locally advanced, they can actually start growing closer to the brainstem, and they can actually impinge on very important cranial nerves as they traverse through the base of skull. And so what I'd first like to do is just highlight what the cranial nerves are. So remember, we have cranial nerves 1 through 12. 1 and 2 technically don't exit from the brainstem, but 3 and 4 exit from the midbrain. 5 through 8 exit from the pons, and 9 through 12 exit from the medulla. And once these nerves exit the brainstem, they sort of travel along the skull base and exit the skull base at various neural foramina. So those neural foramina that they exit through are highlighted in the diagram on the right-hand side. And remember, cranial nerve 1, or the olfactory nerve, exits through the cribriform plate anteriorly. Cranial nerve 2, or the optic nerve, exits through the optic canal. Cranial nerves 3, 4, V1, so the first branch of cranial nerve 5, and cranial nerve 6, those 4 nerves together exit through the superior orbital fissure. Cranial nerve V2 exits through the foramen rotundum, and cranial nerve V3 exits through the foramen ovale. So remember, the trigeminal nerve, or cranial nerve 5, is divided into 3 branches, V1, V2, V3, which are the ophthalmic, maxillary, and mandibular branches, respectively. So V1, V2, V3, there's a nice mnemonic, if you recall from medical school back when we used first aid. The mnemonic is standing room only. So V1 exits through the superior orbital fissure. That's the S in standing. Room is R, stands for rotundum, so V2 exits through foramen rotundum. And then finally, only is foramen ovale, which is where V3 exits from. So standing room only, SRO, the superior orbital fissure, foramen rotundum, foramen ovale, for V1, V2, and V3 respectively. As we move more posteriorly into the posterior fossa, we have the internal acoustic meatus that carries the facial nerve, which is cranial nerve 7, and the vestibulocochlear nerve, which is cranial nerve 8. The jugular foramen has the glossopharyngeal nerve, which is cranial nerve 9, vagus nerve, cranial nerve 10, and accessory nerve, which is cranial nerve 11. And then finally, the hypoglossal canal carries cranial nerve 12, or the hypoglossal nerve. So these foramina are important to know. They can come up on board exams. And, more importantly, whenever we are evaluating for cranial nerve invasion in our patients, we use not only the neurological exam, but if we suspect that there is cranial nerve invasion, we also will get an MRI for better evaluation. And then if there's cranial nerve invasion, when contouring, we typically actually have to trace these cranial nerves back to the brainstem using those neural foramina in our CTV. So that's why it's really important to be familiar with this anatomy, because it actually is incorporated into our radiation treatment design if there is nerve involvement. A couple of more key points about the base of skull anatomy. So we mentioned the superior orbital fissure, which carries cranial nerves 3, 4, V1, and 6. We also mentioned the foramen rotundum, which carries cranial nerve V2. So before these nerves exit the base of skull, if we backtrack a little, these 5 different nerves actually travel together through an area known as the cavernous sinus. And both of these images are kind of showing a coronal section of the cavernous sinus and showing the orientation of these nerves as they travel with the internal carotid artery through this area known as the cavernous sinus. So you can imagine these nerves exit out of the brainstem, and then they travel anteriorly through the cavernous sinus, and then they exit from those different foramina that we just talked about. So in the cavernous sinus, we have cranial nerve 3 and 4 located more superiorly and laterally. We have V1 and V2 located more inferiorly and laterally. And then we have cranial nerve 6, which is the abducens nerve that's located more medially, right underneath the carotid artery. So you can imagine, you can see where the clivus is pointed out here on the image on the right side. And you can imagine if a tumor is invading the clivus, and if it is causing base of skull invasion, because of the proximity of cranial nerve 6, since it's located so medially and closest to the nasopharynx, that might be one of the first nerves that gets involved. And so that's why if there is neural invasion, oftentimes, diplopia can be a sign because of that cranial nerve 6 involvement. And then, of course, if it's even more advanced, then, the other nerves in the cavernous sinus can be involved as well. So again, just reinforcing why it is so important to do a full neurological exam in these patients. And, that exam is really important because it helps us to figure out which cranial nerves might be involved. And then when we get an MRI, we can better correlate those clinical findings. And then finally, the last little piece of anatomy that I want to share is the Meckel's cave, which is located more posteriorly in relation to the cavernous sinus, posteriorly and laterally. And the Meckel's cave is also known as the trigeminal cave because it actually houses the trigeminal nerve and ganglia. And so, the entire trigeminal ganglion goes through Meckel's cave. And then from there, our nerve splits up into its various branches, V1, V2, and V3. And V1 and V2 actually move forward into the cavernous sinus, whereas V3 splits off. So the Meckel's cave is another important anatomical landmark to keep in mind. You can see it pointed out on an axial section of a T2 weighted MRI on the right side. But you can sort of see the relationship between the Meckel's cave and the cavernous sinus. And the Meckel's cave is a little bit more lateral and posterior compared to the cavernous sinus. And believe it or not, sometimes the cranial nerves actually can be visualized on an MRI. Usually, I would say cranial nerve 5 and 7, if they are able to be seen, are the easiest. Cranial nerve 5 is actually the biggest. It's, believe it or not, a pretty fat nerve because remember, it has those 3 branches. So on the left-hand side is an axial section of an MRI showing cranial nerve 5 exiting and traveling towards Meckel's cave. And then on the right-hand side is showing cranial nerves 7 and 8. And, this diagram is nice because you can actually see the separation between cranial nerve 7 and 8. And those are traveling towards the internal acoustic meatus. So this anatomy, again, is very, very important because if patients have perineural invasion along one of these nerves, then we do need to think about tracing those nerves all the way back to the brainstem in our CTV. As we move into our workup for nasopharyngeal cancer, remember we always start with a history and physical, and you won't be surprised how much I'm going to emphasize the importance of a detailed neurological exam. Again, if patients have cranial nerve deficits on neurological exam, that definitely warrants an MRI to better evaluate, and then we can correlate their physical exam findings with what we see on the MRI, and depending on where the perineural invasion is, we then need to trace the path of that cranial nerve back to the brainstem through the foramina through which it traverses, which is why all that base of skull anatomy is so important. Also, of course, a nasopharyngoscopy to better visualize the nasopharynx and visually inspect the tumor. In terms of labs, basic labs including a CBC, a CMP, and we can also perform EBV DNA testing through PCR. And keep in mind that pre-treatment EBV DNA levels are actually prognostic. And in fact, EBV DNA levels after treatment are also prognostic, which we will talk about. And there's an ongoing clinical trial looking at better tailoring therapy based on EBV DNA levels. So keep in mind that EBV DNA levels are very, very important. In terms of imaging, just to reiterate, we always get a CT of the base of skull and the neck with contrast, and then an MRI of the base of skull is really paramount, especially if you are suspicious of neural invasion. A PET CT is really helpful to help assess for distant disease, especially for T3 to T4 tumors and node-positive patients. In terms of pathology, a biopsy of the primary or an FNA of the neck is typically sufficient. And we can also test for EBV on pathology. So in addition to a blood test where we look for EBV DNA, we can also test for EBV on pathology. either through immunohistochemistry, testing for that LMP protein that we talked about, the latent membrane protein, or through in situ hybridization for EBV-encoded RNA, which is abbreviated as EBER. And then the standard evaluations that we do for all of our head and neck patients for reasons that we've enumerated before: dental evaluation, speech swallow nutrition, audiology, as well as smoking cessation counseling. So these are just some of the key pieces to keep in mind for workup. And unique to nasopharynx, I would say, are thinking about EBV testing, whether you're testing for EBV DNA through PCR or looking for EBV on the pathology. And then also, MRI can be applicable in other cases as well, but I think it's especially important for the nasopharynx just due to the proximity to the base of skull. The pathology for nasopharyngeal carcinoma, once we look at that biopsy report, is actually very interesting compared to other head and neck cancers. In a lot of the other head and neck cancers that we've talked about, it's predominantly just been your run-of-the-mill squamous cell carcinoma. With nasopharyngeal cancer, there are a few different subtypes to keep in mind, and the WHO actually has a classification system for these different subtypes. So there are 3 main subtypes to be aware of, and then there is one which is very, very rare. So the very, very rare one is the basaloid subtype, which has this bimorphic pattern with basaloid cells, scant cytoplasm. It's very aggressive, has a very poor clinical course, poor survival, but fortunately it's extremely, extremely rare. So that is one subtype to be aware of. The other 3 subtypes are classified under the WHO classification system. So those subtypes are keratinizing, non-keratinizing differentiated, non-keratinizing undifferentiated. So these are known as WHO type 1, 2, and 3 respectively. So type 1 is keratinizing, type 2 is non-keratinizing differentiated, type 3 is non-keratinizing undifferentiated. So type 3, which is the non-keratinizing undifferentiated subtype, is also known as a lymphoepithelial carcinoma. And this is actually the histology that we see most prominently in endemic areas. And this is the histology that is associated with Epstein-Barr virus infection. It also has the most favorable prognosis. So WHO type 3 lymphoepithelial carcinoma is the non-keratinizing undifferentiated. And the endemic incidence of this is about 95%. The US incidence of this can be somewhere up to 60% range. So it occurs both in the US and in endemic areas, but it is the most common in endemic areas. So that is WHO type 3, non-keratinizing undifferentiated, probably the most important one to know. The other, second most common subtype, I would say, is WHO type 1, which is your typical squamous cell carcinoma. It has keratinizing histology with keratin pearls, intercellular bridges. This subtype is, more like your typical head and neck cancer associated with smoking, occasionally with HPV. You can see the endemic incidence of this is very, very low at around 1%, but the US incidence is higher, around 25 to 30%. So if we see nasopharyngeal cancer in the US, we do have to pay attention to the histology because it could be the WHO type 3, which is associated with EBV infection, or it could be WHO type 1, which is more like your typical squamous cell carcinoma of the head and neck. And then finally, the last subtype that we haven't talked about yet is WHO type 2, which is a transitional cell carcinoma. And this is, I would say, less common both in the US and in endemic countries, although you can see it occasionally. This is another non-keratinizing subtype, except it's differentiated. So it has large trabeculae and nests, no overt keratinization. So hopefully that was an okay summary of the different subtypes that we see on pathology of nasopharyngeal cancer. And again, realize that the histology that we see in endemic areas is lymphoepithelial carcinoma, WHO type 3. So this is a totally different histology than what we see for our run-of-the-mill head and neck cancers. And this is the one that's associated with EBV infection. There is something that I think is a little bit paradoxical about EBV infection and prognosis, because we just said that WHO type 3, which is the EBV-associated cancer, more prominent in endemic areas, this type of cancer is actually associated with a better overall prognosis compared to the other cancers, right? So EBV-associated cancer has a better prognosis. Within EBV-associated cancer, however, having a higher EBV DNA level actually confers a poor prognosis. And this applies whether it's pre-treatment or post-treatment. So having higher DNA titers is actually a poor prognostic factor. So this is a study that looked at EBV DNA level on PCR, and they looked at the relationship between EBV DNA levels pre-treatment as well as post-treatment, and how they impacted progression-free survival and overall survival. And what they found is that pre-treatment, patients that had detectable EBV DNA had significantly worse prognosis compared to patients that had undetectable pre-treatment EBV DNA. And after treatment, you can see that patients that then continued to have detectable EBV DNA had a significantly worse prognosis compared to the patients that converted to having undetectable EBV DNA post-treatment. So having higher EBV DNA levels is a higher risk, a poorer prognosis. And in terms of, in this particular study, they just looked at EBV DNA on PCR and whether it was detectable or undetectable. There are other studies that have used cut points of the threshold. Different studies have used different cutoffs. One study used a cutoff of 1,500. Another study that we'll talk about used a cutoff of 4,000. But basically, the higher the EBV DNA level, the worse prognosis you have. And if it's very high, so just remember the number 4,000, if it's higher than 4,000, you should definitely know that that is a very bad prognostic factor. So bottom line here is higher EBV DNA levels confer a poor prognosis. Now, there is an ongoing trial by the NRG called HN001. And this trial is actually randomizing patients to different adjuvant treatment depending on whether or not that EBV DNA level is detectable. So basically, these patients are treated with IMRT and weekly low-dose cisplatin, and then 1 week after completing chemoradiation, we check their EBV DNA level. And if it is detectable, they are randomized to cisplatin plus 5-FU every 4 weeks for 3 cycles versus gemcitabine plus paclitaxel every 3 weeks times 4 cycles. So basically, they're getting 12 weeks of chemotherapy with either cisplatin 5-FU or gemcitabine paclitaxel if their DNA is detectable, and that's randomized. If they are undetectable in terms of their EBV DNA after chemo-RT, then they are getting randomized to either the same cisplatin 5-FU regimen or observation. So you can see it's basically determining if we can better tailor and better personalize adjuvant chemotherapy based on the detectability of the EBV DNA. So HN001 will definitely be an interesting trial to follow. And I think for now, the big takeaway here is the higher your EBV DNA level in the blood, the worse prognosis. And if it remains high after treatment is done, so after chemo-RT is completed, that is definitely a much worse prognostic factor. Moving on then, let us talk a little bit about the staging for nasopharyngeal cancer. The nice thing about nasopharynx is that there's no sub-classification into T1A versus B or T4A versus B. It's just T1, 2, 3, and 4. So T1 is any tumor that's confined to the nasopharynx. It's allowed to extend to the oropharynx and or the nasal cavity as long as there's no parapharyngeal involvement. So either confined to the nasopharynx or extending a little bit into the oropharynx or nasal cavity, but without parapharyngeal involvement. T2 then is either extending to the parapharyngeal space or with adjacent soft tissue involvement. So something like the medial pterygoid, lateral pterygoid, or prevertebral muscles. So if it's kind of involving adjacent musculature or the parapharyngeal space. T3 is if there is an infiltration of bony structures at the skull base, such as the cervical vertebra, the pterygoid structures, and or the paranasal sinus. So if it's kind of now starting to invade into nearby bones. And then T4 is if we have cranial nerve involvement of the hypopharynx, the orbit, the parotid gland, or extensive soft tissue infiltration beyond the lateral surface of the pterygoid. So one thing to keep in mind is that with a lot of the other head and neck cancers, we say that once there's bony invasion, it's at least T4A, if not T4B. But remember, with the nasopharynx, it's located so close to these bones, including the skull base, cervical vertebra, as well as the pterygoid structures and sinuses. So in nasopharynx, if those bony structures are invaded, then it's really a T3 tumor still. The end staging for nasopharyngeal cancer is also a little bit simplified compared to what we have reviewed for other head and neck disease sites. So there's only N1, N2, and N3. There's no N2A, N2B, and so on. It's just N1, N2, N3. So N1 is anything that's unilateral, less than or equal to 6 centimeters, and above the caudal border of the cricoid cartilage. So in other words, you can't be a level 4 because remember that is below the caudal border of the cricoid cartilage. So it has to be above the caudal border of the cricoid cartilage, and you can have a unilateral cervical lymph node that's up to 6 centimeters, or you can have bilateral retropharyngeal nodes that are up to 6 centimeters. So any of that would be considered N1. So unilateral cervical or bilateral retropharyngeal, less than or equal to 6 centimeters, and it has to be above the caudal border of the cricoid cartilage. N2 is then if you have bilateral cervical lymph nodes up to 6 centimeters in size, and again, these have to be above the caudal border of the cricoid cartilage. Anything that measures greater than 6 centimeters, or anything that's located below the caudal border of the cricoid cartilage that's still a cervical lymph node, that would be considered N3. So above 6 centimeters or below the caudal border of the cricoid, then it's N3. Otherwise, you're N1 or N2. And remember, N1 is unilateral cervical or bilateral retropharyngeal up to 6 centimeters, and then N2 is bilateral cervical up to 6 centimeters. So the end staging, again, is much more simple than it is for a lot of the other head and neck disease sites, and the T staging is as well. So just remember, for nasopharynx, there's no A, B, C within the different T and N stages. It's just T1 to 4 and then N1 to 3. The group staging, I think, is also fairly straightforward and analogous to what we've seen in a lot of the other disease sites. So if it's T1, N0, it's stage 1. If it's T2, N0, or T1 to T2, N1, then it is stage 2. If you are T3 or you are N2, then you're automatically stage 3. And if you're T4 or N3, then you're automatically stage 4A. And then finally, if you have any distant metastases and you're M1, then you're stage 4B. So remember, anything that's node positive is at least a stage 2. If you have T3 or N2, you're automatically stage 3. And if you have T4 or N3, then you're automatically stage 4A. But in a nutshell, that's the group staging for nasopharyngeal cancer. And that brings us to our treatment paradigm for nasopharyngeal cancer. As I've said before, nasopharyngeal cancer typically is not managed with surgery unless in the salvage setting. And really that is because it is such a challenging tumor location. It can be really difficult to access, and it's in really close proximity of some critical nerves and blood vessels. So for all of those reasons, it's really not managed primarily with surgery. With a lot of the other head and neck cancers that we talked about both surgery and radiation as options. But for nasopharyngeal cancer, really it's just definitive radiation, and surgery is reserved as a salvage option. Now, very early stage tumors, so like a T1, N0, M0, so a stage 1 tumor, can theoretically be treated with definitive radiation alone. In practice, however, most of the time, nasopharyngeal cancers are not going to present at such an early stage. Remember, we said earlier that 75 to 90% of these cancers present with nodal involvement. So most of the time, we're going to be just treating them with concurrent chemoradiation. So anything that's stage 2, we think about concurrent chemoradiation, and anything that's stage 2 with positive nodes or ranging up to stage 4A, we actually not only do chemoradiation, we also think about either induction or adjuvant chemotherapy. The principles of radiation and chemoradiation are, largely the same as everything that we have talked about previously. In terms of possible doses, we can go to 70 gray in 35 fractions. And when we do that, we do kind of a simultaneous integrated boost approach. There's also a possibility of doing a sequential boost approach. So everything is not going to 70 gray, but we have different dose levels. Another possible dose is 69.96 gray given in 33 fractions. So these are just some of the possible doses that we use. In terms of lymph node coverage, remember nasopharyngeal cancers, they do tend to spread to level 5. So we actually include the retropharyngeal and levels 2 through 5 bilaterally, typically when we're treating nasopharyngeal cancer. So just keep in mind kind of that unique fact about the lymph node spread, which is that we do need to cover not only the retropharyngeal levels 2 through 4, but also level 5. And then another unique thing about treating nasopharyngeal cancer is that when we actually have metastatic patients, so if you have a stage 4B tumor with positive metastases, we actually think about adding local regional radiation if patients have a good response to their initial chemotherapy. So there is actually data that definitive local regional radiation improves outcomes in patients even with metastatic nasopharyngeal cancer if they have a complete or partial response to initial chemotherapy. And then we can also employ radiation for oligometastases as indicated. So those are just some unique kind of features about the treatment of nasopharyngeal cancer. But otherwise, the principles that we apply are largely the same as what we have discussed in our general principles talk. Normally in the treatment paradigm section, I like to talk a little bit about the unique surgical considerations, chemotherapy and radiotherapy considerations as well. But as we said, surgery really is not utilized as the primary treatment for nasopharyngeal cancer, and the radiation principles really are not different from what we've talked about already in our general principles talk. So I'm just going to spend a few minutes focusing on chemotherapy, and then we'll get into the evidence base for management of nasopharyngeal cancer. So in terms of chemotherapy, as we've already said, nasopharyngeal cancer is a little bit unique in the sense that induction chemotherapy is actually something that we can utilize specifically in the management of nasopharyngeal cancer. The best evidence for induction chemotherapy is really for EBV-mediated cancer. So that's that WHO type 3 non-keratinizing undifferentiated subtype. Typically, it's EBV-mediated cancer where we think about induction chemotherapy based on the evidence. And the regimens that we utilize are something like gemcitabine and cisplatin, given every 3 weeks for 3 cycles. So the cisplatin is 80 milligram per meter squared on day 1, and gemcitabine is 1,000 milligram per meter squared day 1 and day 8. There's another regimen known as TPF, which is docetaxel, cisplatin, and 5-fluorouracil. That's also given every 3 weeks for 3 cycles total, and that's another option in terms of an induction chemotherapy regimen. And then in terms of concurrent chemotherapy, again, just to review, typically cisplatin 40 milligram per meter squared weekly is preferred. There's probably better data for 100 milligram per meter squared given every 3 weeks, and that's what was used in a lot of the historical trials. But we know that with the high dose given every 3 weeks, there's a higher risk of toxicity. And the NCCN guidelines even state that giving cisplatin-containing induction therapy followed by high-dose cisplatin every 3 weeks is actually associated with significant toxicity concerns. So we would ideally prefer giving a lower dose of cisplatin once weekly, so that dose is 40 milligram per meter squared weekly. So those are some of the considerations for induction and then concurrent chemotherapy for nasopharyngeal cancer. That brings us to our last leg of the talk, which is the evidence base for management of nasopharyngeal cancer. Now, in our general principles talk, we did spend a lot of time going through evidence for different dose fractionation schemes and which lymph node levels should be covered and things like that. And I would refer you to that talk for more detailed discussion on the evidence for dose fractionation. In this particular talk, the majority of the studies that I discuss are really going to focus on the chemotherapy that we utilize for nasopharyngeal cancer and the sequencing of that chemotherapy. So the data for adding concurrent chemotherapy and also both adjuvant as well as induction chemotherapy. So the discussions that we have are really going to focus on considerations around systemic therapy predominantly. And as we go through this data, you will see that there are some studies that specifically looked at the EBV DNA levels as a prognostic indicator. So we'll talk a little bit about that as well. The first trial that I'd like to mention is the Intergroup 0099 trial, which looked at the addition of concurrent and adjuvant chemotherapy with definitive radiation. So this is a fairly old trial. It was initially published in 1998 with an update in 2001. But this was a trial of just under 200 patients with T3 to T4 or node-positive nasopharyngeal cancer. And they called it stage 3 to 4 nasopharyngeal cancer. It might have included some modern-day T2 tumors. And they randomized these patients to either radiation alone to a dose of 70 gray or radiation with concurrent cisplatin, high-dose cisplatin given every 3 weeks, and adjuvant cisplatin 5-FU given every 4 weeks for 3 cycles. So concurrently, they got cisplatin, adjuvantly, they got cisplatin 5-FU. And interestingly, only 63% of patients were able to complete their concurrent chemo, and only 55% completed the adjuvant chemo. But despite that, what they found is that the addition of concurrent and adjuvant chemotherapy significantly improved both overall survival and progression-free survival. So the 3-year overall survival improved from 47% up to 78% with chemotherapy, and at 5 years it was 37% up to 67%. So remember, somewhere around 40% up to somewhere around 70% with the addition of chemo. And then the progression-free survival at 5 years improved from 29% up to 60%. So for overall survival, it went from 40 to 70%, and for progression-free survival, it went from 30 to 60% with the addition of chemotherapy. This trial was actually terminated early given the poor outcomes for radiation alone. So the big takeaway from this intergroup trial is that the addition of concurrent and adjuvant chemotherapy significantly improves overall survival and progression-free survival for locally advanced nasopharyngeal cancer. Now, this was an intergroup trial, right? So it was a collaboration actually between SWOG, the RTOG, as well as the ECOG. So these are all kind of Western cooperative trial groups. And so these patients that were enrolled on the trial were not in an endemic population. So you can assume that they had a lot of keratinizing squamous cell carcinoma, given that it was a non-endemic population, and many of the cancers might not have been EBV mediated. So whenever you're looking at these trials, given that we see different histologies depending on where the patients are located, whether it's an endemic area or a non-endemic area, it is really important when you're looking at these trials to kind of bear that in mind. So do bear that in mind that these results were considered to have been obviously practice changing, but also may not necessarily be applicable to endemic regions where we're more likely to have EBV positive cancers. There are a few different trials that evaluated the role of concurrent chemoradiation, specifically in endemic regions. So a lot of these trials came out of China or neighboring countries, specifically looking at the benefit of chemoradiation in endemic regions. So there was NPC 9901 and then a second randomized trial by Lin et al., so the top 2 rows of the table. And both of these trials took pretty much stage 3 to 4 patients, and they randomized them to either radiation alone or radiation with concurrent chemotherapy. Both of these trials were positive, and they showed a significant improvement in the progression-free survival with the addition of concurrent chemo to radiation alone. The second trial actually showed a significant overall survival benefit as well. The last trial that's in the table was by Chen et al., and it was published a little bit later in 2012. And it also took stage 3 to 4 patients. But now, instead of comparing radiation alone versus concurrent chemoradiation, it was actually comparing chemoradiation versus chemoradiation followed by adjuvant cisplatin and 5-FU. This trial was negative for any benefit, and the 2-year failure-free survival was just around 85% in both arms, and there was no improvement seen to adding adjuvant chemotherapy after chemoradiation. So based on these trials that are listed here, as well as the intergroup 99 trial, which we already talked about, it seems that in both endemic and non-endemic nasopharyngeal cancer, adding concurrent chemotherapy is definitely beneficial. And remember, all of these trials that we've talked about so far were predominantly including stage 3 to 4 patients. So adding concurrent chemotherapy to the radiation for stage 3 to 4 nasopharyngeal cancer seems to be beneficial. That Chen et al. Trial from the Lancet might, add a little bit of controversy since it was a negative trial, and it might call into question the role of adjuvant chemotherapy for this endemic nasopharyngeal cancer. But I don't think based on this trial, people have concluded that adjuvant chemotherapy should not be done because we have the intergroup trial. We also have an additional meta-analysis, which we'll talk about. But it's important to know that this trial was negative specifically, but I think it's also important to realize in the context of the other studies that have been done, I don't think that people have completely, crossed out the role of either induction or adjuvant chemotherapy for nasopharyngeal cancer. It's just important to know that this trial was negative. So that brings us to this meta-analysis that I was just mentioning. It's also known as MAC-NPC, and it stands for a meta-analysis of chemotherapy for nasopharyngeal cancer. And this meta-analysis included about 7,000 patients across 26 different clinical trials with locally advanced nasopharyngeal cancer. And what I've shown here is Kaplan-Meier curves for overall survival, looking at plus or minus induction chemo, plus or minus concurrent chemo, plus or minus adjuvant chemo, and then concurrent and adjuvant or induction and concurrent. And what you can see is that the greatest differences, the greatest improvement with the addition of chemotherapy was seen with the addition of concurrent chemotherapy to radiation. So if you're going to do either induction, concurrent, or adjuvant, you should do concurrent chemotherapy because that showed the greatest benefit. However, if we look at the concurrent and adjuvant and induction and concurrent groups as well, the addition of adjuvant or induction chemotherapy to concurrent chemoradiation also improved tumor control and also improved survival. So I think the big takeaway here is that concurrent chemoradiation is definitely beneficial compared to radiation alone, and actually adding either adjuvant chemotherapy or induction chemotherapy in addition to concurrent chemoradiation is kind of the best to maximize your tumor control and survival. And this trial showed that the addition of chemotherapy provided an absolute survival benefit of around 6% at 5 years and around 8% at 10 years. So in general, for any disease site, and this applies to a lot of different disease sites, I think, including small cell lung cancer, non-small cell lung cancer, those are the two I can think of off the top of my head, and now nasopharynx as well. Adding chemotherapy to radiation seems to provide an absolute survival benefit of around 5% generally if they ask you that on boards. So remember, 6% survival benefit at 5 years, 8% at 10 years. So this meta-analysis is also important because it kind of establishes the role for adding chemotherapy to the radiation for nasopharyngeal cancer. So far, all of the studies that we have looked at have really used locally advanced nasopharyngeal cancer, so predominantly stage 3 and stage 4 tumors. this Chinese study looked at the benefit of chemotherapy for stage 2 nasopharyngeal cancer. And they knew that prior studies had showed improved outcomes when you add chemotherapy for stage 3 and 4 patients. But the question was really, what about stage 2 patients? So they took about 230 patients and randomized them to radiation alone or concurrent chemoradiation. And what they found is that chemoradiation significantly improved the overall survival and the distant metastasis-free survival, both by around 10%, but they did not include they did not improve the local regional recurrence. So the local regional recurrence was just around 92% in both arms, but the overall survival improved by 10% from 86% up to 95%. Distant metastasis-free survival also improved by about 10% from 84% up to 95%. On multivariate analysis, they found that the number of chemotherapy cycles was actually the only independent factor that was associated with overall survival, progression-free survival, and distant control in stage 2 nasopharyngeal cancer. And they, of course, found higher acute toxicity with chemoradiation, but actually the late toxicity was fairly similar. So the big takeaway here from this Chinese randomized trial is that adding concurrent chemotherapy, even for stage 2 nasopharyngeal cancer, provides an overall survival and a distant metastasis-free survival benefit. The key data for induction chemotherapy has really come from China, and for that reason, these studies were done predominantly in endemic populations. And that's why previously when I was saying the best data for induction chemotherapy is really for endemic populations, so predominantly non-keratinizing, EBV-mediated nasopharyngeal cancer. That's why I said that. So there's 2 trials that are important to know. One, first author is Sun et al. The second is Zhang et al. And both of these trials took patients with stage 3 to 4 non-keratinizing nasopharyngeal cancers, and they randomized them to either chemoradiation or induction chemotherapy followed by chemoradiation. The first trial used an induction regimen of TPF, which is docetaxel, cisplatin, and 5-FU, and found about an 8% improvement in 3-year failure-free survival, so 72% with chemoradiation alone, up to 80% with induction chemo. The second trial used the induction regimen of gemcitabine cisplatin, and they actually found about a 5% improvement in the 5-year overall survival, a 10% improvement in the 5-year overall survival from 79% up to 88%. They found a significant improvement in the failure-free survival, distant metastasis-free survival, and local regional free survival as well. And on subgroup analysis, they actually found that the greatest benefit to induction chemotherapy was seen in patients that had a pre-treatment EBV titer of greater than 4,000 copies per milliliter. So remember we talked about that 4,000 cutoff earlier, and the greatest benefit to induction gemcitabine cisplatin was seen with higher pre-treatment EBV titers. So the big takeaway here is that induction chemotherapy also improves outcomes in patients that have locally advanced nasopharyngeal cancer. And these studies were conducted in China, where EBV is endemic. And based on this data for EBV-mediated cancers, oftentimes for these locally advanced tumors, people will give induction chemotherapy with the idea that this can hopefully help to shrink things, elucidate whether or not patients have risk for distant metastasis, and kind of weed out folks that don't progress and have distant metastasis, and maybe help shrink our radiation fields a little bit, at least our high dose radiation fields. So that's kind of the impetus for induction chemotherapy, and we now have this data that it improves outcomes. And so I think induction gemcitabine cisplatin is the most common regimen that I've seen used, but induction TPF is also an option. These are just some Kaplan-Meier curves taken from that second Chinese study by Zhang et al., and it shows, the significant improvement in overall survival with the addition of induction chemotherapy. They saw about a 10% improvement there, and they actually found that if you look at graph B, the response to induction chemotherapy was actually predictive of overall survival. So patients that had a complete response versus a partial response versus a suboptimal response, had different survivals. And so you can kind of see how those curves separate there. The final set of curves from this trial that I'll draw your attention to is these curves separating the benefit in overall survival from induction chemotherapy based on the EBV titer. So patients that had greater than or equal to 4,000 copies per milliliter are shown in curve A, and you can see that they had a significant improvement in their 5-year overall survival if they had a high EBV DNA titer. If the EBV DNA titer was lower, if it was less than 4,000 copies per milliliter, they really did not see an improvement with the addition of induction chemotherapy. So this is a subgroup analysis, and anytime we do subgroup analyses, we always have to take them with a grain of salt because it wasn't randomized based on the copies or anything like that. But basically, this is just showing that we see a greater improvement in survival within the induction chemotherapy if they have a higher EBV DNA titer. And remember that was, that's a prognostic marker. And the higher that copy number, the worse the overall prognosis. So that is something that we can definitely monitor. It's a blood test, and we can measure EBV DNA based on PCR. And the last trial I want to discuss in this sort of systemic therapy section is the DIPPER study, which was very, very recently published. And it was also presented in the Quad Shot News article. And this trial was a randomized trial out of China, again, in an endemic population, looking at patients with very locally advanced nasopharyngeal cancer, so T4N1 or N2 to N3 patients. These patients were randomized after induction chemo and concurrent chemoradiation to either observation, which is the current standard of care, versus adjuvant PD-1 blockade with a drug called chemoralizumab. So I don't know if I'm pronouncing it correctly, but it's a PD-1 blocker, and they were given this drug every 3 weeks times 12 cycles. What they found is that there was a significant improvement in the event-free survival with the adjuvant PD-1 blockade. So the 3-year event-free survival improved from 77% with observation up to 87% with the addition of that drug. And interestingly, 86% of the patients in the immunotherapy arm actually had a reactive capillary endothelial proliferation, which is a rash that is actually similar to the cetuximab-induced rash that has been associated with improved survival in patients that get that rash with cetuximab. So that's just an interesting little tidbit that they did kind of highlight in the Quad Shot News article as well. But the key takeaway here is that this DIPPER trial looked at adjuvant PD-1 blockade specifically for patients with very locally advanced nasopharyngeal cancer in an endemic population, and found that there was a significant improvement in the event-free survival. So I'm sure that will be studied further and may end up resulting in a change in the treatment paradigm. So that was certainly a lot of evidence, a little bit confusing perhaps, but the big takeaways here are pretty much what we summarized in our summary of management. So stage 1 nasopharyngeal cancer, T1N0M0, can theoretically be treated with definitive radiation alone, but remember, it's going to be very rare that patients actually present with such early stage disease because more often than not, they're going to have more advanced disease or lymph node involvement, just given how nasopharyngeal cancer presents. Stage 2 nasopharyngeal cancer, remember we showed that randomized trial out of China that showed a benefit to concurrent chemoradiation. And then for more locally advanced tumors and with node positive cancers especially, so think stage 3 to 4 and anything that's node positive, we really do see a benefit with concurrent chemoradiation and either adjuvant or induction chemotherapy. So adjuvant chemotherapy has really been shown to be beneficial for both keratinizing and non-keratinizing subtypes, but the induction chemo regimens, including TPF and gemcitabine cisplatin, really have shown the most benefit in endemic populations. So that's just something to keep in mind, and keep in mind that a lot of patients, especially with EBV-mediated cancers, are going to be treated with induction chemotherapy if they are this advanced. And then finally, we briefly mentioned the DIPPER trial, which showed a benefit to PD-1 blockade for endemic, very locally advanced nasopharyngeal cancer. There's only one more trial that I want to present, and it's a clinical trial showing a benefit to local therapy for patients with metastatic nasopharyngeal cancer. This trial was also out of China, and it looked at the benefit of locoregional radiation for patients with de novo metastatic nasopharyngeal cancer. So they basically took patients that had biopsy-proven metastatic nasopharyngeal cancer, and 70% of patients had 3 or more metastases. And these patients were first treated with 3 cycles of cisplatin 5-FU. And as long as they had a complete or partial response to the upfront 3 cycles, they were then included in the study. And after 3 cycles of chemo, they were either randomized to 3 more cycles of chemo for a total of 6 cycles, or 3 more cycles of chemo for a total of 6 cycles, followed by loco-regional IMRT to a dose of 70 gray. So they did not get concurrent chemotherapy, but they got IMRT to the standard fields that we would treat with radiation for loco-regionally advanced cancer. So the primary tumor and the elective lymph nodes as well. And what they found is that overall survival and progression-free survival were both improved with the addition of loco-regional radiotherapy. So the 2-year survival went from 55% with chemo alone up to 76% with the addition of radiation. And the hazard ratio for this was 0.42. The hazard ratio for PFS was actually 0.36. So both of those were statistically improved. They found no significant difference in hematologic side effects between the groups, and in terms of radiation-related effects, they had an 8% rate of grade 3 or higher dermatitis, 34% rate of grade 3 or higher mucositis, and 7% rate of grade 3 or higher xerostomia. So the bottom line here is that there is phase 3 data out of China showing improved overall survival and progression-free survival with loco-regional radiation for metastatic nasopharyngeal cancer. So maybe for these metastatic patients that have a complete or partial response after upfront chemo, we should be thinking about giving loco-regional radiation, given that it has shown a benefit. So that brings us to an end of everything that I wanted to talk about for nasopharyngeal cancer. I know a lot of that data was very kind of systemic therapy heavy and not a whole lot to do with radiation, except for at the very end where we talked about the role of radiation for metastatic patients. But I do think that the chemotherapy data is important to understand because typically when we're treating with definitive chemoradiation for other disease sites, we don't always think about adding either adjuvant or induction chemotherapy. But in the case of nasopharyngeal cancer, there is data for that as we've gone over. So hopefully this was helpful in kind of understanding the rationale and putting together some of the salient features of nasopharyngeal cancer that makes it unique from the other head and neck disease sites. For those of you that are following along with the weekly Radonc Talks videos that I'm posting, first of all, thank you so much for your support. I'm really happy that these videos are helpful to you. I do want to say that after this video on head and neck cancer, I'm probably going to take a break from head and neck cancer and move on to some other disease sites because there's still a lot that I have to cover. I've certainly not covered everything in head and neck. There's still, salivary gland tumors, thyroid cancers, sinonasal tumors. So there's a lot that we could cover and a lot more detail that we could get into with head and neck cancer itself. But I think just to be a little bit holistic and try to address some of the other disease sites, I'm going to take a break from head and neck for now. My hope is in the future I can come back and fill in some of those gaps. But there's a lot of other videos I want to create. I also want to start creating videos on contouring and plan evaluation, which is very popularly requested. So for that reason, I think I'm going to move on from head and neck for now and maybe come back to it in the future. But that said, thank you so much for your support. I really appreciate all of the feedback and the requests for videos that I've been getting, trying to definitely get to them all. But again, thank you so much for your support, and I hope these videos are helpful to you, and good luck with studying.